Hello and welcome. I hope you enjoyed today's webinar, which is exploring cardiovascular risk for people living with diabetes. This presentation will look at the current guidelines and new therapies which are available. The aim of today's session is to refresh knowledge on the risk of cardiovascular disease for people living with diabetes, to review current guidance on the management of the 3 treatment targets. These are cholesterol, blood pressure, and glucose levels, and also to explore new therapies and their evidence base in managing glucose levels and cardiovascular risk. So let's consider the current situation and why it's important to be aware of the risk of cardiovascular disease in people with diabetes. In 2017, there were 425 million people living with diabetes. It is predicted that by 2045, there will be more than 600 million people living with diabetes. It is clear that the prevalence of diabetes is increasing, with 9 out of 10 cases of diabetes being type 2 diabetes. Diabetes is an independent risk factor for cardiovascular disease. In fact, diabetes increases the risk for cardiovascular disease by 2-fold. This risk is greater in women and in those who have diabetes for longer. This is made more concerning by the rise of diabetes, particularly type 2 diabetes, in young adults under the age of 40, which is aligned with an increase in childhood obesity over recent decades. We also know from recent NDA data, National Diabetes Audit data, of young adults who are less likely to have all annual review care processes or a HbA1c less than 7.5%. Observational studies have shown that the age of diabetes diagnosis, glycemic control, and renal complications were the major determinants of cardiovascular outcomes, thus emphasizing the need of intensive management of cardiovascular disease risk in these age groups. It is important to recognize that COVID-19 is a multi-organ disease which also affects heart health both directly and indirectly. As well as diabetes influencing cardiovascular health, falling ill with COVID-19 increases the risk of cardiac injury, with the prevalence between 8 to 12% of all patients. It has been consistently shown that the presence of pre-existing cardiovascular disease and/or the development of acute cardiac injury are associated with significantly worse outcomes in these patients. In fact, one meta-analysis found that cardiovascular disease and its risk factors, such as hypertension and diabetes, were closely related to fatal outcomes in COVID-19 for patients across all ages. Specifically, the presence of hypertension increased the chances of fatal outcomes by 2-fold, diabetes, which increased the fatal outcomes by 2-fold, and pre-existing cardiovascular disease, which increased the chance of fatal outcomes by 3-fold. The effects of COVID-19 on heart health is also evident in COVID recovery. A cardiology study used cardiac MRIs on 100 people who had recovered from COVID-19 within the past 2 to 3 months. Researchers found abnormalities in the heart of 78% of recovered patients and ongoing myocardial inflammation of 60%. The same study found higher levels of blood enzyme troponin, an indicator of heart damage, in 76% of patients tested, although heart function appeared to be generally preserved. Most patients in the study had not required hospitalization, and this explains some of the common symptoms seen in COVID recovery, which include a rapid or irregular heart rhythm, chest discomfort, feeling lightheaded or dizzy, especially on standing, which is also called postural orthostatic tachycardia syndrome, also known as POTS. People living with diabetes mitigate their cardiovascular disease risk by managing 3 treatment targets: cholesterol, blood pressure, and glucose levels. We call all of these the 3 T's. Let's recap on current guidance for managing each of the 3 T's. So, first of all, let's look at the definition of cardiovascular disease and what defines high risk. The latest 2020 EASD guidance defines someone being at high risk of cardiovascular disease if they have had diabetes for longer than 10 years without organ damage or other additional risk factors, and being at very high risk of cardiovascular disease if they have established diabetes and established cardiovascular disease, or organ damage such as proteinuria, renal impairment, ventricular hypertrophy or retinopathy, or 3 or more risk factors such as increased age, hypertension, dyslipidemia, smoking, obesity, or early onset of type 1 diabetes for a long duration, i.e. longer than 20 years. The NICE recommendations suggest using a Q risk score. The Q risk score estimates the risk of cardiovascular disease looking at multiple risk factors, including age, sex, ethnicity, location, smoking status, heart disease risk, diabetes status, chronic kidney disease, blood pressure, cholesterol level, and BMI. The dietary and lifestyle guidance for managing cholesterol and blood pressure hasn't changed much in recent years. We know that smoking is a leading cause for cardiovascular disease and is responsible for 1 in every 4 deaths from cardiovascular disease. Specifically, smoking can lead to atherosclerosis, narrow blood vessels, and increased blood pressure. So stopping smoking will greatly reduce this risk. Exercise has a great effect on triglycerides by lowering them, and on HDL, the good cholesterol, by increasing it. Regular exercise is also known to help reduce blood pressure. Therefore, it's recommended that someone with diabetes aims for around 150 minutes of moderate exercise a week. Research indicates that weight loss of 5 to 10% of body weight may significantly reduce LDL cholesterol, also known as bad cholesterol, in people at a higher risk of cardiovascular disease risk. Weight loss has also been correlated with a positive effect on blood pressure and reduces the need for hypertensive medication. Studies have shown that the consumption of whole grain diets lowers LDL, bad cholesterol, and total cholesterol. Likewise, foods higher in saturated fat, like fatty processed meat, butter, or ghee, increases LDL and also body weight. So eating less saturated fat has a positive effect on cholesterol and blood pressure. Reducing sugary food can help to reduce visceral fat in the body and blood pressure, and guidance still encourages 5 portions of fruits and vegetables a day. Oily fish, particularly oily fish high in omega-3 fats, which are known to reduce inflammation in the body and reduce the risk of heart disease. Nuts, seeds, and legumes are also a good source of good cholesterol, HDL, and therefore are also recommended. Finally, cutting back on alcohol helps to reduce blood pressure, but also helps to reduce triglyceride levels in the body. So currently, NICE guidance recommends the prescribing of atorvastatin 20 mg once daily for the primary prevention of cardiovascular disease in those with type 2 diabetes. This should be offered to those who have had a Q risk score that suggests a greater than 10% chance of a 10-year risk of developing cardiovascular disease. Secondary prevention is to increase the dose of the statin to 80 mg once daily. In terms of managing blood pressure, the target for blood pressure is set at less than 140/90 or 130/80 if they have albuminuria or 2 more features of metabolic syndrome. Treatment should be to offer an ACE inhibitor or an ARB for anyone with type 2 diabetes of any age, or a calcium channel blocker for someone of African Caribbean background. GLP-1 agonists and SGLT2 inhibitors are the most recent class of medications to come to the market for the treatment of type 2 diabetes. Over the last 10 years, numerous studies have identified the benefit of these medications in reducing the risk of cardiovascular disease and heart failure in this group of patients. Some of the benefits of these medications are that they help to reduce HbA1c, they don't come with an increased risk of hypos, and they also support weight loss. The disadvantages of these medication classes are that GLP-1s are injectables, so not necessarily preferable to all patients. However, there are now GLP-1 tablets which are on the market. but also that these medications sometimes come with unwanted side effects. The latest EASD and ADA guidance encourages the use of GLP-1s and SGLT2 medications to reduce MACE, or also known as major adverse cardiovascular events. Also, they help to reduce the risk of heart failure, cardiovascular death, and CKD, chronic kidney disease progression. These should be considered as an add-on therapy as well as metformin and lifestyle interventions, and should be considered irrespective of glycemic control. Add-on therapy should also be considered whether the patient has established cardiovascular disease. So let's look at the evidence behind these new therapies. Starting with GLP-1 agonists, each drug has undergone cardiovascular outcome trials, all of which have shown non-inferiority, no increased risk of major adverse cardiovascular events, cardiovascular death, or non-fatal MIs and non-fatal strokes. Liraglutide, subcutaneous semaglutide, albiglutide, and dulaglutide have all shown superiority in reducing the risk of these events. Semaglutide, liraglutide, and dulaglutide have all shown significantly fewer nephropathy events. And interestingly, these drug effects on cardiovascular risk reduction were tightly associated with the efficiency for lowering HbA1c, implying that cardiovascular risk reduction and improved glycemic control might follow the same dose-responsive curve, which is why it is important to consider intensification of therapy to avoid clinical inertia. If HbA1c remains above target, the EASD and ADA guidance supports combining GLP-1 therapy with SGLT2 therapy. So why do GLP-1 agonists help to reduce risk? Well, we know that this medication group impacts a number of cardiovascular risk factors, such as improving glycemic control by reducing body weight, reducing blood pressure, reducing fasting and postprandial cholesterol levels, and also reducing inflammation in the blood vessels. Next, let's look at SGLT2 inhibitors. Clinical research has demonstrated that SGLT2 inhibitors reduce the risk of cardiovascular events, such as cardiovascular death, non-fatal heart attacks, and non-fatal strokes. This was seen in clinical trials for canagliflozin and empagliflozin, but not dapagliflozin. The research shows that the benefit of cardiovascular risk are not attributed to glucose control, and there was no association between baseline or achieved glucose levels and the cardiovascular or kidney outcomes. Only modest association between HbA1c and the risk was found. Notably, all SGLT2 inhibitors significantly reduce the risk of heart failure. Again, there are multiple reasons why SGLT2 inhibitors reduce cardiovascular disease risk, and these may include lowering blood pressure, also associated with reduced arterial stiffness, reductions in weight and visceral fat, which reduces cardiac inflammation, increasing in red blood cell concentration, which can improve oxygen supply to the heart, osmotic diuresis, so passing more urine, which reduces arterial stiffness and blood pressure, and natriuresis, so passing more sodium in the urine, which reduces arterial stiffness and blood pressure. Also, reductions in the risk of worsening nephropathy was found, and this may be attributed to a reduction in the rate of albumin urea progression and a reduced worsening of nephropathy, also possibly due to increase in oxygen delivery to the kidney. So in summary then, cardiovascular disease is more prevalent in people with diabetes and a leading cause of death. It's important to think about the 3 T's: cholesterol, blood pressure, and glucose levels. It's important to think about contemporary treatments such as diet and lifestyle advice, statins, and antihypertensive treatments like ACE inhibitors, ARBs, and CCBs, but also consider emerging therapies such as GLP-1 agonists and SGLT2 inhibitors. Here are a list of my references. Thank you all for listening, and I hope you have found this webinar useful.